friends. This evening we are starting our session into three halves, three parts. First, we will discuss the medical management of benign prostate. Second, we will discuss the TUR syndrome which was left over in day before yesterday's lecture. And the last, the most important topic, the art of persuasion. A surgeon without art of persuasion is only 2/3 of his skill. I will elaborate how the art of persuasion makes a difference in the life of a surgeon and the life of his followers, friends and family. So we will go one by one. Let's start from the medical management. Friends, the TUR started getting popular sometime in 75 and in 80 it was at peak, because by this time several centers across the world, more so even in India, they were active. When I was learning TURP, after New Delhi to Pakistan, PGI Chandigarh and CMC Ludhiana, these were two hospitals where TUR was done regularly in good volume and quality. Now, same time, if I share the data with you, 87, we don't have any Indian data. In 87, 2.5 lakh people underwent TURP in United States. Then came the medical management. And as the medical management advanced, as the understanding of physiology improved, the incidence of TUR fell down to 80,000. So 2087, next 13 years, it became 1/3. And if we give a genuine trial, if our decisions are not financially biased, because if I tell somebody, this is your lifestyle modification, which we discussed last time, these are your tablets, they will cost you 400 rupees a month, and keep taking the tablet and you will live well. Now what do I get? One consultation, two consultation? If I tell him, you undergo a urgent surgery, otherwise your kidneys will fail, I can make few thousand rupees. Remember last time, I'm trying to remind a very important fact, that moderate amount of residual urine is not correlated into repeated urinary tract infections. It is not related to renal failure, which is a common excuse for patient to be subjected to surgery, because in our country there are no guidelines. The guidelines are there only till we pass our exam. Subsequently, everybody has his own experience. Well, not going into that detail, but if we go real scientifically, in last 25 years, my number of prostates requiring surgery has gone down by 75%. Means 3 out of 4 patients get well with medical management. So now let us try to understand. We have already discussed when the surgery should be done. So today we are discussing only the medical management. The main principles are already done. So it was, let me share with you one of my very initial experience. sometime in 81, the British Journal of Urology published that the prostatic urethra has lot of alpha receptors and their dominance increases more so in paraplegics or paraparesis patients. So the first patient I had when I was rotating in paraplegia ward, somebody who is undergoing repeated cystoscopy every 3 months and there is no obstruction, he is dilated, he is sent home, still doesn't have any improvement. So having read that, it was first time in Ludhiana we tried to do a test called, this is just historical to involve your interest, that first time a test called pharmacocystourethropy was done. What is pharmacocystourethropy? You do a conventional urethrogram, you find an obstruction in the prostatic urethra. You give that patient phenoxybenzamine, which at that time, phenoxybenzamine was the only alpha blocker available. It had a lot of side effects. You give phenoxybenzamine, the patient passes a good stream and you document on radiology that the obstruction has disappeared. So that was an era of phenoxybenzamine. Some people got benefited. So alpha adrenergic blockers are useful because there is a lot of mediation of bladder neck obstruction with adrenergic fibers in prostatic smooth muscles. Tension of prostatic smooth muscles have increased level of epinephrine in human prostates. Now, as a general surgeon, you need to know the broad classification that the alpha blockers are non-selective like phenoxybenzamine, alpha 1 blockers, long-acting blockers, and subtype selective. Good evening, Professor Maheshwari, pranam. And subtype selective alpha blockers like temsolon. There are variety of names which I will not like you to confuse into. All the alpha blockers, the commonest use is temsolon, and 0.4 milligram is the normal dose, and you can go up to 0.8 milligrams. It helps to relieve the baseline obstruction. It is considerable benefit even in irritative symptoms, and the total prostatic score improves with, and the results come much earlier compared to dutasteride, which we will discuss later. There are 2-3 names you don't need to remember. Though leave the difficult job for urologist friends to think over. Your job is you should know side effects of temsolon and the action, and you have to distinguish between dexazosine, temsolin and alpha-zosine. Alpha-zosine SR 10 mg gives the same results, but it is uroselective. There is no drop of blood pressure. Doxazosine affects the blood pressure also. By far the effects of all of them are similar, and temsolon and alpha-zosine are better tolerated. No, I would normally give temsolon 0.4 milligram BD. Okay, that answers your question. And if we come to the guidelines, as per guidelines, alpha blockers improve international prostate severity score, peak flow rate. There is an interesting complication because it is the same group which undergoes prostatectomy also undergoes cataract operation. So there is a complication called intraoperative floppy iris syndrome. That means if a patient is on alpha blockers and undergoes cataract operation, there is a difficulty because the iris becomes floppy. The ejaculation is affected by all alpha 1 blockers, and alpha blockers should be recommended to moderate to severe symptoms of LUTS with 40 grams prostate or so. The second broad group is 5-alpha reductase inhibitor. There are two types, type 1 and type 2. The type 1 has expression in skin and liver, and type 2 has expression in prostate. Now, finasteride is type 2. It is affecting only the prostate. And dutasteride affects 1 and 2 both receptors. They produce prostatic apostosis. The size decreases from 15 to 30%. And thus, remember an important issue, this is what examiners are fond of, that if the PSA is 5 of a patient who is on dutasteride, so you should assume it is 10 because it makes the circulating PSA to 50%. The efficacy in long term from 2 to 4 years, it improves the IPSS, it decreases the volume of prostate, and the Qmax is increased from 0.5 to 2 ml per second. Greater the prostatic volume, more is the relief. Remember a cross difference between alpha blockers and 5-alpha reductase inhibitors, or grossly temsolon and dutasteride, is that dutasteride decreases the incidence of AUR, acute urinary retention. It decreases the need of surgery, but not the temsolon. The effect of dutasteride comes approximately 3 months onwards. You need to tell the family. And 6 months is the optimal effect. Now the guidelines say use dutasteride group for moderate to severe LUTS which have increased risk of progression of disease. That means 40 gram onwards. The onset of action is 3 to 6 months, and if a patient has gross hematuria, remember this is an important point to remember for you, for your practice. The examiner may not ask you, this is a difficult question, but a given patient who has gross hematuria, finasteride is better than dutasteride. In modern era, that is one indication of using finasteride over dutasteride. Then there is a group of drugs. Now, primarily, these are 2 drugs which are used for prostate. Now, there are a couple of drugs which take care of LUTS and international prostatic severity score by the virtue of acting on the holding capacity or on the detussor. As now we do not consider the disease process purely as prostatic obstruction, because LUTs have several components as we discussed the other day. So there are muscarinic receptor inhibitors, and the standard example is tolterodine, phosphodiesterase, and sulforaphane. Now these drugs act on the diffuser because their neurotransmission is through acetylcholine. So they inhibit the acetylcholine function, and thereby they improve the prostatic score. And if while you start on these drugs, if the score worsens or the stream narrows, then they should be discontinued. The guidelines say the anti-muscarinic receptor antagonist can be used in mild to moderate LUTs when there are storage symptoms. Do not use them when the PVR is more than 150 ml. Then there is another group which is seldom used in practice, but you need to know for some fancy examiners or for your theory question. It is phosphodiesterase 5 inhibitors. They produce reduction of smooth muscle tone in diffuser, prostate and urethra. And Cedanophil 5 mg OD is the dose, and you know all the contraindications of Cedanophil. And the main contraindication means patient on nitrates. You can be, if your question is on ED, then the gravest mistake the examiner can ask you is, which you may commit, is that what drugs are contraindicated with Cedanophil. So, welcome dear Jha. So you need to know patient with coronary artery disease and patient on nitrates are contraindicated. Then there are beta 3 agonists. They are also seldom used, but mirabegron is a drug which is contraindicated in hypertension, can lead to acute urinary retention. Practically there is no long-term data on beta 3 agonists, but it is known that this drug takes care of certain situation where there is increased frequency of micturition and irritable type of bladder. The patients, the benefits are still doubtful, and the last drug is phytotherapy. These are from roots and plants, pills created from roots and fruits of the plants. Only Serena reprins has a definitive benefit, all others are controversial. If you can remember the name, fair enough. If you cannot, if you can say, sir, there is phytotherapy and they are of borderline benefit, and that's all what you need to know. And then it comes the combination therapy. The commonest used combinations are finasteride and dutasteride on one end as alpha reductase and alpha blockers on the other side. Like the commonest uses tamsulosin, and the dual combination has better alpha blockage. Now guidelines, what do the guidelines say? Alpha blockers are better than placebo, better in symptoms and improvement of Qmax. Patients who get combination therapy for 6 months, after 6 months, if you withdraw tamsulosin, dutasteride alone can carry on the patient well in 75% of the times, but 25% will demand restarting the treatment. People who have larger gland or who have higher body weight At times we start with 0.4 milligrams of Temsilon in the morning and in the evening, and once the patient improves over 3 to 6 months, then gradually withdraw first 0.4 milligrams of Temsilocin. That is all about the medical management. Now, few words about TUR syndrome. It is the rapid infusion of, good evening Dr. Pandey. It is the rapid absorption of large volumes of irrigation fluid. Intravascular volume shift, and it has a plasma and solute effect. How does it affect the body? It affects primarily at 3 levels. Number 1, CVS. In CVS, it produces hypertension followed by hypotension, bradycardia, arrhythmias, respiratory distress, cyanosis, and shock. Then it affects by hemolysis and affecting the kidney, increase in serum glycine, increased serum, good evening Dr. Girish, and ammonia, sodium, fall in sodium, fall in osmolarity, and hemolysis and acute renal shutdown. On central nervous system, the presentations are nausea, vomiting, confusion, seizures, and coma. Now, what is the mechanism? Now, first thing is, only those smart surgeons pick up the complication. Remember this dialogue. It is the smarter group of surgeons which pick up the complications because they move ahead of the complications. They think things can go wrong. It is not like with duopologist, the gynecologist, मैंने किसका कभी बुरा किया है, मेरे साथ तो कभी हो ही नहीं सकता बुरा, right? So we should have an attitude to anticipate, accept, and treat. So when do you anticipate a complication? When do you anticipate a water absorption or a glycine absorption? Is when the gland is large, when the resection time is long, when the amount of irrigation used is large, when you have had capsular perforations. That is what, and imagine it can be absorbed at the rate of 20 to 200 ml per minute, and the net gain of the patient's body weight may be up to 2 kg. Now, how to estimate the fluid absorption? Young friends can write down the formula. Since Dr. Katyal is here, I would like to tell everybody that, we are childhood friends. He is here first time on the Facebook site. Now, the best TUR complications are given where? It is not, best TUR syndrome is not given in any urology book. Let me must share with you. The best textbook for all the boys who are interested should read Yaws and Artu's Anesthesiology. The best details for TUR syndrome are only given here, and I am quoting from this book. The volume of fluid absorbed is calculated by a formula, preoperative sodium divided by end of the surgery sodium multiplied by ECF, extracellular fluid, which is around 20 to 30%, minus extracellular fluid. So very simple formula. When you want to study this, you can always do the serum sodium at the beginning of the case, do the serum sodium at the end. Suppose it is 140 to begin with and 100 to finish. So it is 100 divided by 140, it becomes 0.4 multiplied by ECF. ECF is say 20% of the body weight. So 60 multiplied by 20 minus again ECF. So that is the calculation. Now, duration of operation and TUR syndrome are not correlatable till 2.5 hours statistically. If somebody is meticulous, not having lot of bloodshed, if the level of the height is at 40 centimeters, if the venous sinuses are not open, if the intravesical pressure doesn't rise because the gentleman is careful during the section, then till 2.5 hours nothing happens. Why CNS symptoms? Sodium doesn't cross the blood-brain barrier that easily, but water does. So it is the brain edema and convulsion because the water travels across the membrane. What are the prophylactic measures? Prevent capsular perforation. Less than highest height should be 60 centimeter. When I say 60 centimeter, from the center of torso to the highest point of the glycine bottle, that should be 60 centimeter. And whenever the serum sodium intra-op drops to 120, tell your surgeon if you are the anesthetist, or ask your assistant to find out, and same time it should be abundant. Well, therapy is very standardized, and I don't think I should spend more time on TUR syndrome. You can read up the therapy yourself. So let me take a sip of tea and then we shift on to the next interesting topic, which is a non-surgical skill for a surgeon, the art of persuasion. It is very important. Most successful surgeons have this art. Yes, yes. Thank you, Shah. That's the reason. I love your words. So, well, don't imagine I'm taking some scotch. This is the heat is coming out of my thermos. Let me start with an example. Cassandra was one of the most beautiful lady, princess in ancient Greek era. And she fell in attention of Apollo. Apollo wanted to marry Cassandra. Cassandra put a precondition: if you fulfill my wish that I would be having the gift of prophecy, I will marry you. So Apollo was in so much love with Cassandra, he gave her the gift of prophecy, that she could see, anticipate what is going to happen. But once she got the gift, she changed her mind on the day of wedding. And Apollo got very angry. He could not take the gift of prophecy back. But he cursed her that even when you can predict what is going to happen, even when you see the future, nobody will believe you. So Cassandra lived with gift of prophecy and a curse of nobody would believe her what she said. She could foresee that his brother Hector will be killed in the war with Achilles. She said so, nobody believed. She could see the fall of her own empire. She told her everybody, but nobody believed because she was having a curse. So, dear friends, if you are a surgeon with the curse of Cassandra, if whatever you speak, nobody is going to believe, then imagine the life. Cassandra had a curse. But here, in a surgical perspective, I'm not talking about a curse. I'm talking about a lack of skill set. Welcome, Dr. Rahul. A lack of skill set for which the public, your team, your other friends will not believe you. And if they don't believe you, how can you grow? 2300 years ago, Aristotle wrote a book on the art of persuasion. He also said it is art and science of persuasion. And he said persuasion is three things. Logos, which he meant my belief and your belief are the same. We come to a point where the other party also thinks similarly, like what you think. Ethos, when there is a creditability, trust, reputation, transparency, when people believe what you say. Pathos, which meant emotions, the connection with other person with emotions, with a reason, and the other guy believing that what you are talking is in his or her interest. You are not talking about your own interests. So, persuasion is an art, like surgery can be learned, like laparoscopy can be learned, like AWR can be learned. So is the art of persuasion can be learned. Friends, there are 6 points which built the art of persuasion. What is persuasion? Persuasion is the other guy, making the other guy believe in what you believe, to follow what you think he should follow, and to agree with you. So, the first point is reciprocity, means reciprocal action with each other. But that has to start from you yourself. A response to a gift, favor, or a nice behavior is what is always reciprocated in the same way. The typical example which Colonel Neil gives is, you go to a restaurant. The waiter, along with the bill, gives a cookie for you and says, this is a mint or cookie. If he gives that, the gift becomes 3% of the bill. Imagine if he doubles up, this is a scientific study, if he doubles up his gift, the tip becomes 14%. And if after leaving 2 minutes, he moves away from the table and then comes back and says, For such a nice couple, I have one more mint for each one of you. Who would not appreciate this? Now, from this philosophy, what I drive and share with you, you have an elderly man in ICU, you did a bowel resection, the anastomose leaked. You reoperated him, did an ostomy. He's on ventilator. In your heart of heart, you know, at least I know, that maybe it was error of judgment on my part. Had I done ostomy to begin with, this day would not have come. The family doesn't know. I will also say the family is careless. Whenever you want, they are not there. But how do I approach them? I will say, have a seat in my counseling room. I will always, that old man whom nobody bothered with his bowel perforation, he was at home for 6 days. But I would still start, instead of asking, are you related to that old man inside on bed number 7? I would say, how is Mr. Om Prakash ji related to you? Then somebody will say, I'm his son, his son-in-law. Then I start saying, I know you people are putting in best of your effort. You have spent time, energy, your prayers. And I appreciate your concerns. When you are telling a third-class guy such nice words, he will never dare to reciprocate. This is the theory of reciprocity. When you start yourself being very nice to him and to his father, he dare not ever talk rough to you. He will follow your every advice by saying, yes sir, yes sir. How to get a difficult person on reciprocity? When I say, you are such a nice son to him, what will be his answer? Yes sir. Then I'll say, you are so much taking care of your father. I give a pause, he will say, yes sir. Then I'll say, I feel your concerns. You spend your time, money and energy. What is the answer? Yes sir. Now I say, we are putting our best in skill, equipment and concern. What will be the answer? Again, yes sir. So the theory of reciprocity is very important in medicine for the persuasion. Now, the second theory is theory of scarcity. There is a story when flu vaccine was introduced in America, nobody bothered about how the theory of scarcity came in to convince people. And nobody was utilizing it. Then the company put up in the paper that the flu season is coming, but we are in short supply of vaccine. Vaccine is going to finish. Everybody ran with the news, vaccine is going to finish. So everybody was in the line of vaccine. Now, one small tip to the youngsters. When you have only one patient in the casualty, in your OPD, leave your OPD. Go and sit in your coffee room. Wait for crowd to build in. Nobody wants to show to a doctor where there is only one guy waiting. Suppose the patient comes to you, then you ask, when would you like to undergo surgery? This, lot of senior guys use this trick. I saw one of my senior professor doing this. Somebody will say, he will ask, when would you want? They will say, whenever you give time. Then he will just take out a diary out of his pocket and he'll just open like this. Then he will with a smile will say, sorry, we are occupied for 2 weeks. He will give a pause. Then look at the family. The family is worried. He has created scarcity of availability, of time. Then he will say, maybe I can fit in you somewhere tomorrow around afternoon. Now what is the answer? Yes, sir. So even a double-minded patient, he has got admitted. So tomorrow, I know I have no OPD appointment. So if somebody comes and sits in my OPD, and he is the only patient, what impression is going to say? If I tell him I create scarcity, I said you can come at 10 a.m. If you come at sharp 10, I can see you, because I have to start a major operation at 10:10. That fellow will be there. That look, this doctor has no time, but still he has given me opportunity to be examined. Right? So scarcity is something like that. Then authority. Well, I am not in full-time private practice. I was always more a teacher and less a practitioner. By virtue of less availability of equicompetent people, we had a lot of business. But authority, how do you exert your authority? The authority comes when you, in your office, you have lot of certificates hanging over. That you are, I don't even like to write those half a dozen degrees of FAIAMS, FAICS, FAL and things like that, because it is everybody's own individuality. Everybody has his own style of exerting authority, right? So authority comes, your office wall. Well, I am not a practitioner. This wall, instead of books, is all medals and the mementos given in last conferences. You are very nicely dressed up, a bright red necktie, a black blazer, blue blazer, or a long coat with lot of degrees and nomenclature written here. Or the authority comes when somebody outside your office introduces you and speaks high about you. It may be your receptionist, maybe your public relation officer who says, oh, this doctor has no time. He does 10 gallbladders a day. Let me share a funny story. One of my close friends, he had kept a guy who would keep praising about him in OPD. And once the income tax people came for survey, so this fellow said, the officer said, how much surgery your doctor does? He says 10 cases every day. And he says, how much he charges? He says, he doesn't charge less than 30,000 rupees. So the guy with a very low practice was trapped. Eventually they found out the culprit is his own well-wisher. So authority has to be exhibited by one way or the other to convince somebody, to persuade for you. And consistency of your results, of your commitment, of your conduct. Now, quoting, there is a great example. All Padma Shris in India, 90% of them are delivered in Delhi. Does that mean doctors in Delhi are brighter than elsewhere? No. Because the important people live in Delhi. The Prime Minister, past Prime Minister, the Home Minister, the President of India, they are all here. So when they will undergo a hernia surgery, will he Prime Minister undergoing a hernia surgery? Will he have 5 sacs? No, he had the same sac. He has the same one ilioinguinal nerve, one iliohypogastric nerve. Suppose there is a big religious teacher. Will that preacher have 5 cystic ducts? No. He had only one cystic duct, one cystic artery, like a leper. But then, to show consistency, a big photograph of that preacher or of that mantri or of that, president, vice president is put up. That gives a consistency that the people look at how highly placed people also trust this doctor. Then, like. The 5th point is like. Somebody will be persuaded by you when he likes you. How does somebody like another person? Number 1, when you are similar to him in some area. I will give you an example. Somebody talks to me in Punjabi. I say, where do you belong to? He says, I'm from Amritsar. In one dialogue I say, most of my maternal uncles lived in Amritsar. Does it make any sense? No. Does it make any value to the patient? Yes. Let me tell you, if we are traveling in a Delhi bus, you talk to the next guy, and if he is talking in Punjabi, he will say, where from you are? He says, I'm from Ludhiana. He said, I was in Ludhiana for 13 years. That starts a link. And when you are in New York, you see another Indian, then you say, where from? He says, I am from India. He says, I am also from India. So, some link is required for a connection to be built. The following will start later on. Then people like, second point, whoever compliments them. You tell a 85-year lady, when she comes second time in your OPD, he says, ab to vajan kam ho gaya lagta aage se. She will hold her breath, pull her tummy in and smile. He says, yes, I'm trying. Nobody likes, nobody. Remember one dialogue which I tell 3 times a day to my team. Remember, your dog doesn't like criticism. What to talk of anybody else? Then the third like comes from cooperative to mutually beneficial things. When I am talking something from core of my heart, which is useful to the other guy. When there is a connection built, the conversion rate of following you, listening to your advice, carrying on as per your wish becomes several times higher than otherwise. The last point is consensus statement. You put up what you want. You need to convince that your statement is already followed by a variety of people. I carry a board in my hospital. If you write no smoking, nobody is going to stop smoking. If I write, कृपया बीड़ी बाहर पीजिए, please smoke outside, looks more sensible to that guy. I can make somebody quit cigarette when he has come for a hernia repair to me. That is the time when he is receptive. When he has come to visit a neighbor, he is under no influence of mine. If you say, if you put up a sticker that most people who lived here never smoked inside the room, if that gives a consensus that in past also nobody has done it, we appreciate your cleanliness, which is good for you, and all have done it. So involve towards a consensus statement, something which is already happening. You say you also become part of it. So friends, when it comes to persuasion, it is the theory of being reciprocal, scarcity, authority, consistency, liking, and consensus statement. And one thing I must tell you, the last conclusion of this is, how do you connect emotionally? The best thing to connect emotionally is tell a story. Start with a story. Feel the other guy, the intensity of it. You know, in communication, the strongest language is the language of silence. Give a pause in between. The pause gives you opportunity to speak for longer time. It gives an opportunity to cool your head. Now, I will give you an example. I gave it 2 months ago also, but it is worth for young people to know this. You are supposed to come home at 9 p.m. and you got stuck, your case got delayed, and on a lot of traffic on Delhi roads, pushing through here and there through the small streets in a jam, you reach home 45 minutes late. There is your spouse waiting red hot, opening the door with a swollen face. There is the common dialogue, you are late. Before you can think, there's another dialogue again, you are always late. Now what I said, the power of silence. If you yell back at the same time that no, on Monday I was in time, on Thursday also I was before time, you can't understand my problems, you are planning to have a bad weekend. Today's sermon is follow the formula of interesting. You go to the office, your boss says your operation note is not written. You have not completed your assignment. Always start interesting. Speak this word interesting slowly within your head, not through your larynx. Interesting. That will give you 15 seconds to cool down your head. Give a calculated response. You may say, and then use the formula of reciprocating the tool by agreeing with the other person. You start saying, I agree I am late. Now you already accepted you are late. So 50% of the issues are over. If you are not written the notes, you say, I apologize. I did not write the notes. Now, once you say so, after a pause, if you say, sir, I accept my failure of not having completed the assignment. Now, once you have said this, the other guy will cool down and he will listen to you. Welcome, Bhaskar. Probably you have heard this earlier. So, what I'm trying to say, cool your head, take the other person along with you, give respect, lead from the front. People should understand, if you want to persuade them to be punctual, you have to be punctual. If you want them to be kind, if you want them to be soft-spoken to the families, you have to be. If you want your residents to thank the scrub nurse, first you have to thank the scrub nurse. If you want your resident to follow the WHO safety list, you have to do the timeout first. Until you don't demonstrate your leadership qualities, the things cannot improve. Now, thank you very much for being with me till quite late every day. Every day it has become an addiction for me. 9:30 is my transmission time, and it's nice to interact with young and not so young, and having a couple of my own teachers on this platform, and senior friends, Professor Maheshwari, Dr. Rajkumar Sharma, and several others, and Dr. Rahul Mahadar. Thank you so much for being with us, and I want all youngsters to be better than me one day, so that even when I'm not in this mic, some other people will carry on the flame. LGS is going on in a big way, 6 lectures in a day. We only started from a very small family, and look at the young talent. How many young speakers are coming out every day, and we are full of knowledgeable young chaps. We are just expiry capsules trying to inspire you guys, and I think is a long way to go. Even when I hope soon the corona story will be controlled, and once it is done, probably instead of 6, I should be able to take at least 3 lectures every week, and we will take your opinion, and how and where we go after urology, and so encouraging to know young people across the country. And I think we will have a session tomorrow again, depending upon how busy I am tomorrow, and I will put up the notice early morning. And because of Facebook reasons, when I am going to talk about carcinoma penis, it will be always referred as carcinoma spine. You rearrange the spelling in your mind. Okay, so that's an information today. Thank you very much, Dr. Lingo Setu, being with us, and do listen to the later half of the lecture whenever you are free. Okay, good night. Have nice sleep.